Hi guys, welcome back to my channel. I hope you all are doing fine. So welcome to the part 2 of the OSCE Made Simple series. I recently published a video of part 1 of the OSCEs where I discussed about 20 clinical questions and I left one question for you to answer. So about 21 questions I discussed, where I discussed in detail about the types of questions which can be asked, the framework of the questions which are being asked, and also I gave you the answers and how one should write and how you should prepare it. In this part 2, we will be continuing with the furthermore questions from various other topics and to give you more insights of how the things can come up in the exams, and these are basically more of a recall based sessions which are collected from our seniors, from my own experience. If you have not watched part 1, you can watch it from the link in the description or from the I button. But before we start, hi, I'm Dr. Nishant. I am currently a senior resident in the Department of General Medicine at Apollo Hospital, Guwahati. If you are new to my channel, please make sure to subscribe and hit the bell icon so that you don't miss on such videos. And you can also find the entire PDF of the OSCE questions and the answers, and also the PDF of the questions only, so that you can also practice at your own ease. I would also suggest to stop the questions when displayed on the screen and write the answers on your own so that you have a practice along with the video. So the first question: a 45-year-old alcoholic male presents with fever, foul smelling sputum, cough and weight loss for 3 weeks. He reports an episode of loss of consciousness after binge drinking 1 month ago. On examination is febrile, has clubbing and coarse crepitation in the right upper lung field, and a chest x-ray is shown below. The questions are: what is the most likely diagnosis? Name 2 common predisposing factors. Mention 2 most common causative organisms. Outline the first line management and list 2 complications if untreated. So you can see an x-ray. Clearly a cavity like structure is seen at the right upper zone of the lung with a air fluid level with a thick border, and with the setup of the clinical history, there is a fever, alcoholic, foul smelling sputum, cough and weight loss for 3 weeks. That's a prolonged one, and he's also having clubbing. It is pointing more towards a lung abscess. So the diagnosis is lung abscess, and predisposing factors are definitely aspiration, alcoholism, seizures, stroke, poor dental hygiene, any form of bronchial obstruction in the form of tumor or foreign body, any hematogenous spread. So you have been asked to you have to write any 2. Causative organisms are anaerobes from the oropharynx, they are bacteroids, Pepto, Streptococcus, Fusobacterium, etc., Klebsiella pneumoniae and Staphylococcus aureus. The first line management is prolonged antibiotics, and remember BL-BLI combinations or clindamycin. Clindamycin is an important drug in treatment of lung abscess. Also sometimes you might need postural drainage, physiotherapy, supportive care in the form of fluids, nutrition, oxygen, and in certain scenarios surgery or percutaneous drainage is needed if the case is refractory. Complications: it can turn into an empyema, it can turn into a massive hemoptysis, there can be a bronchopleural fistula and a chronic lung abscess with fibrosis. Next question: you are posted in a COVID ward. The following items are to be disposed in a color coded bins available: red, yellow, blue, black, white, and items on the table are the PPE kit, a used COVID mask, soiled patient dress, used catheter bag, there is a urine drainage bag, and a syringe cover. And the questions are: you have to match it with the correct color coded bag or container, and also you have to mention the method of treatment for each category. For example, if you are disposing it in the red, so how will you treat the red one? If you are disposing the yellow, how will you treat the yellow one, and so on. So this is a very common question asked from PSM, that is about the biomedical waste management, and you have to know this. This is a COVID scenario which is being given. You can be given any scenario. You can be given a normal ward scenario or ICU scenario, and this is a very scoring if you know. So let us first see the correct color coding. So PPE kit will go into a red bag. A used COVID mask, since it is a used one, it will go into yellow bag. It is an infected biomedical waste. Then a soiled patient dress, of course, again it's a soiled waste, it will go into yellow bag. Catheter bag, urine catheter bag, it will go into a red bag. And the syringe cover, it is a plastic cap, will go into a red bag. So remember, the things which you want to recycle generally goes into a red bag, and which you want to discard it goes into a yellow bag. And the methods of disposal: the red bag items generally undergo autoclaving, microwaving or hydroclaving for recycling or shredding, and yellow bag items, there is a mask or the soiled dress, undergo incineration or deep burial. So that is about the biomedical waste management. Please go quickly through the recent guidelines and read about what things which should be discarded in which part. Also read about the cytotoxic drugs and the needles, where it should be thrown. It's very important. Then the next question: a 30-year-old female presents with progressive fatigue, numbness in feet and glossitis. On examination, she is pale with a smooth, beefy tongue and mild splenomegaly. Blood smear shows macroalveolocytes and hypersegmented neutrophils. Identify the condition, name two common causes. What additional investigation would you order to confirm the diagnosis? Outline the acute management and mention two complications untreated. So they have already mentioned about the PBS findings also, macroalveolocytes and hypersegmented neutrophils. Sometimes they might not mention, you have to identify yourself. You can clearly see there are big RBCs which are macroalveolocytes, and the neutrophils you can see definitely there are more lobes, at least more than 5 to 6. So it's hypersegmented neutrophils also. So this is one of the most common question which is being repeated again and again. You can say this is like a full toss which is being given to you. This is always asked in one or the other exam. It's a very important and an easy question which you can't miss. So of course the answer is megaloblastic anemia, very easy. The causes are the vitamin B12 deficiency and folate deficiency, the two common causes. Investigation you like to do would be definitely serum vitamin B12 levels and the folate levels, bone marrow in certain cases, not all, homocysteine and methylmalonic acid levels you can check, and anti-IF antibody you can check if pernicious anemia is being suspected. But you have been asked investigation for 2 marks. If you can mention 2, that will be enough. Acute management, of course, you have to correct the vitamin B12 deficiency. You can give it a parenteral loading, then a maintenance, and also oral folic acid supplementation. And complications, if untreated, can lead to irreversible neurological deficits, for example, subacute combined degeneration of the spinal cord, infertility, recurrent abortions, and there is also increased risk of gastric carcinoma. So this is a very important and a quite common question which have been asked repeatedly in the previous exams. Then the next question, a 12-year-old boy from Odisha presents with recurrent episode of joint pain and pallor. He has a history of repeated blood transfusion. On examination, pallor, mild icterus and splenomegaly are noted, and a PBS image is given below. Identify the condition, what is the underlying genetic defect, name to laboratory tests to confirm, outline the acute management of the vaso-occlusive crisis, and mention 2 long-term complications of the sickle cell anemia. It's very clear from the PBS study also and from the history also. There is a repeated blood transfusion history, there is a pallor, mild icterus, splenomegaly, and clearly you can see sickle shaped cells in the PBS study. So there is no brainer for a diagnosis of sickle cell anemia. But now comes the question part which you have to answer correctly. So as straightforward from the question is sickle cell anemia. The genetic defect is the point mutation in the beta globin chain, that is substitution of the valine for the glutamic acid at the position 6, which leads to formation of HbS instead of the normal hemoglobin. The diagnostic tests are the sickling tests and hemoglobin electrophoresis, that is HPLC, which is gold standard. Acute management, that is a crisis, you have to give adequate hydration, which is the most important step. You can give oxygen, analgesics, and you have to treat the underlying infection if present. Complications, they can be stroke, they can be avascular necrosis of the bone, recurrent infection, pulmonary hypertension is important complication, and chronic renal disease. So these are the important things which you should know about the sickle cell anemia. It's a very important. You can even be given a question of beta thalassemia, and similar questions can be asked around it about the chelation therapy and so on. So one question for hemoglobinopathy can be expected. It's an important one. Then comes the next question. A 52-year-old taxi driver presents with complaints of unrefreshing sleep, early morning headaches, frequent dozing off while driving. His wife reports loud snoring and periods of breathlessness at night. On examination, his BMI is 31, neck circumference 44, and blood pressure is 150/95. You have to identify the most likely condition, 2 risk factors, gold standard investigation for a diagnosis, first line non-pharmacological management, 1 device and 1 surgical option for the treatment. I think from the history you are around able to get what the diagnosis is. The patient is having daytime sleepiness, dozing off while driving, he is having unrefreshing sleep, which is important. His BMI is high, so he is obese. Wife is reporting of loud snoring, and also his blood pressure is high, so another comorbidity. So of course something like obstructive sleep apnea comes to your mind when you see this question. So the answer is obstructive sleep apnea. These factors are definitely obesity, as in this case, short neck, alcohol use, craniofacial abnormalities, and various comorbidities which are associated with it. The gold standard investigation is the polysomnography, that is the sleep study. Non-pharmacological management is the weight reduction, avoidance of alcohol, sedatives, and positional therapy. And the treatment, the 1 device which can be used is CPAP, which is a commonly used device. 1 surgery which can be done is the uvulopalato-pharyngoplasty or maxillomandibular advancement. These surgeries are done in very selected and severe cases. Also, the criteria and the grading of OSCE is important, that is the mild, moderate, and severe based on the AHI score, which I will suggest you should read about it. Then comes the next question. A 40-year-old male presents with recurrent sinusitis, nasal stuffiness with occasional epistaxis, and hematuria for 2 weeks. On examination, he has a saddle nose deformity and a bilateral basal crepitations. Urine analysis shows red cell cast. CT scan shown below. What is the most likely diagnosis? Characteristic antibody associated with this condition, 2 common organ system involved, standard induction therapy, and 1 potential long-term complication if untreated. So you can see cavitary lesions in the CT scan with a clear history of sinusitis, nasal stuffiness, active urine, that is an important clue, saddle nose deformity, and bilateral crepitations. Urine analysis is showing red cell cast. So there is active urine, there is involvement of the lung, and there is also recurrent sinusitis. Definitely an autoimmune condition. And the answer is the Wegener's granulomatosis, where the cavitary lesions are more common. Antibody, of course, is CNK, that is antiproteinase 3. Organ systems involved are the upper respiratory tract, lungs, and the kidneys more commonly. Kidneys generally rapidly progressive glomerulonephritis, lungs with nodules and hemoptysis, and upper respiratory tract with sinusitis, nasal septal perforation, epistaxis, and so on. Induction therapy, of course, you have to give high dose steroids, cyclophosphamide or rituximab. Complication, this condition is left untreated, there can be a end stage renal disease, pulmonary hemorrhage, and death. So it's very important to act early and identify this disease. This is a very important form of vasculitis which is being asked in exams commonly. Also, side by side you should read about Church-Strauss, that is about EGPA, and also about the MP. Next question, a 28-year-old male presents with sudden onset weakness of both lower limbs for 2 days. He reports urinary retention, constipation. Examination, the tone is decreased in both lower limbs, power is 1/5, reflexes are absent, plantar reflexes are mute. Sensory level is noted at T10. What is the clinical finding described? 2 important differential diagnosis of acute flaccid paraplegia. Immediate investigation would you order, emergency management steps, and 2 complications that may occur if untreated. So the answer is acute flaccid paraplegia. As per from the history, the reflexes are not there, the tone is reduced, and differentials are definitely acute transverse myelitis, spinal cord compressions, and GBS. Investigations to do is to MRI to rule out the compression is very important, CSF analysis, blood test, and viral markers. And the emergency managements are to ensure airway breathing circulation is the first step. A high dose IV steroids if transverse myelitis is suspected. Urgent neurosurgical referral if compression seen on the MRI, and supportive care for the urine, that is the catheterization, for the constipation like the anemia, DVD prophylaxis, physiotherapy, and so on. And certain complications like pressure sores, UTI, contractures, and permanent paralysis can occur. This is again an important clinical scenario, a case-based scenario, which can also be given as a long case, can come up in OSCEs. Then a 55-year-old female, non-smoker, presents with progressive exertional breathlessness and dry cough for 8 months. She has a history of joint pains and morning stiffness. On examination, bibasal and inspiratory velcro crackles are heard and clubbing is present. A CT chest is given below, and the questions are as follows. What is the most likely diagnosis based on the CT finding? 2 important causes or risk factors, investigation, which is the gold standard for diagnosis of ILD pattern, 2 pharmacological options for the treatment of this condition, 2 complications. If you see the CT, it's typical of the ILD. You can see a lot of honeycombing and the traction bronchiectasis and so on. So I think this is a image spotter, also one of the very favorite topics of the examiners. So the diagnosis is idiopathic pulmonary fibrosis, that is the usual interstitial pneumonia. Honeycombing, traction bronchiectasis mostly found in the UIP pattern. Causes and risk factors are connective tissue disorders, occupational exposures, drugs, and idiopathic. Gold standard investigation is the HRCT, which has been done in this patient. Pharmacological options are pirfenidone, nintedanib as antifibrotic agents, and certain complications of important one are the pulmonary hypertension, respiratory failure, and the lung carcinoma. Then the next question, a 22-year-old male presents with sudden onset weakness of all 4 limbs since early morning. He was normal the previous night but reports having eaten a heavy carbohydrate meal before sleep. On examination, power in all 4 limbs is 2/5, tone is reduced, reflexes are diminished, and sensations are intact. There is no respiratory distress. ECG shows a flattened T waves and prominent U waves. What is the most likely diagnosis? 1 precipitating factor, immediate management, long-term prophylactic drug which can use to prevent recurrences, and mention 1 life-threatening complication if not treated properly. So the clinical question, the clue is the sudden onset weakness which is being precipitated by a heavy carbohydrate meal, and the power of the 4 limbs are 2/5, the tone is reduced, the reflexes are diminished, and another important ECG finding is being given, that is flattened T waves and prominent U waves. So I think you can correlate which direction the diagnosis is going. So yes, it's hypokalemic periodic paralysis. The findings of the ECG are of hypocalcemia, and the way it is being presented, it's a periodic paralysis. The precipitating factors are the high carbohydrate meal. When there is a high carbohydrate meal, a lot of insulin is released, which pushes the potassium into the cell, causing hypocalcemia, and such paralysis results in. Other precipitating factors are the strenuous exercise, stress, and high salt intake. Immediate management, of course, you have to correct the potassium via infusion, and since there is ECG changes, you have to give it IV. Prophylactic drug acetazolamide can be given, and complications are respiratory muscle paralysis, which can lead to respiratory failure or cardiac arrhythmias. Then a 60-year-old hypertensive male presents with sudden onset right-sided weakness and altered sensation for 2 hours. His BP on arrival is 200 by 110. On examination, GCS is 10 by 15. Right hemiplegia is noted. Pupils are equal and reactive. And a CT brain is given below. What is the most likely diagnosis on CT? Name 2 common risk factors for this condition. 2 poor prognostic features, immediate management emergency, and 1 complication due to intraventricular extension. So you can clearly see a hyperdense lesion, of course, in the CT. It is the area around is the basal ganglia, I think, and there is definitely a intraventricular extension. So definitely a diagnosis is the left basal ganglia intracerebral hemorrhage with an intraventricular extension. The risk factors are the hypertension, anticoagulant use, cerebral amyloid angiopathy, and vascular malformations. Poor prognostic factors are definitely large hematoma volume, low GCS at admission, intraventricular extension, and brainstem involvement. And immediate management, of course, airway, breathing, circulation is very important. Strict BP control is very important. So IV antihypertensive, in this case it's 200 by 110, so you have to reduce the BP to stop any anticoagulants or any antiplatelets if the patient is on. And in this case, since there is a big hemorrhage with an intraventricular extension, you have to give a neurosurgical consultation, and surgical evacuation might be needed in selected cases. Complications, of course, obstructive hydrocephalus due to the clot, raised ICP, and sudden deterioration of the patient can occur. So this is again a very important spotter which can be given in the OSCEs. It can also be asked in your table vivas as a CT scan. So you have to know through and through about this topic. Then the next question, a 24-year-old male presents with a painless swelling in the left side of the neck for 3 months. He also complains of intermittent fever, night sweats, and weight loss. On examination, a firm, rubbery, non-tender cervical lymph node is palpable. A biopsy is shown below. What is the most likely diagnosis? Classical cell seen in the histopathology. 2 types of this condition. The staging system commonly used, and the 2 long-term complications. So from the clinical scenario, it's clearly mentioned it's a painless swelling in the left side of the neck. So there's definitely lymphadenopathy, and there are also B symptoms, intermittent fever, night sweats, and weight loss. And the characteristic of the lymph nodes is being given as a firm rubbery type. So I think the differentials are quite few. And if you see the biopsy, a typical characteristic cell is being shown. So definitely the diagnosis is Hodgkin lymphoma. The histological cell which is being shown is the RS cell, that is the Reed-Sternberg cell. There are 2 types basically, the classical Hodgkins and the non-classical Hodgkins. Classical includes a nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted types, and the non-classical is the nodular lymphocyte predominant. And the biomarkers also different in the classical and non-classical types. Then the staging is the most common is the Ann Arbor staging. And the complications, of course, there are secondary malignancies, there is infertility, there can be hypothyroidism and cardiotoxicity due to chemotherapy. So this is one of the common hematological oncology topic which you can't miss. Then another question, a 30-year-old male from Bihar presents with fever for 2 months, significant weight loss, and progressive abdominal distension. On examination, he has pallor, hepatosplenomegaly, dark skin over hands and face. Laboratory reports show pancytopenia. A splenic aspirate is demonstrated as below. What is the most likely diagnosis? Name the causative organism, mention 1 specific diagnostic test, what is the drug of choice for treatment in India, and list 2 complications left untreated. I think it's a very common case scenario which is being given, and the clinical history, a male from Bihar, type of history as hepatosplenomegaly, dark skin over hands, and the characteristic image. I think the diagnosis is very easy and is a very common topic of interest which is being asked by the examiners over years. Definitely the diagnosis is Kala Azar. Causative organism is Leishmania donovani. Diagnostic tests are a splenic aspirate of the bone marrow showing the MST gut form which we saw, or we can also nowadays rapid diagnostic kits are available where we test for RK39 antigen. The drug of choice in India is of course liposomal amphotericin B at a single dose. Other options are miltefosine, amphotericin B deoxycholate, and paramomycin. And complications are severe anemia. There's a dermatological condition as post Kala Azar dermal leishmaniasis, secondary infections, and bleeding due to pancytopenia can occur. Kala is one such topic. Malaria, Kala Azar, tuberculosis, HIV. These are certain infectious diseases which you can't miss. They are being asked repeatedly. So you have to know everything about this. Another one, a 25-year-old male, a resident of Assam, presents with high-grade fever with chills and rigor for 5 days, associated with headache and body ache. On examination, he has splenomegaly and mild jaundice. And PBS is shown below. What is the most likely diagnosis? 2 diagnostic methods, 2 features suggestive of severe form of disease, the first line drug in India, and mention 1 complication. I think again another spotter, very easy questions. You can see the ring forms of the malarial parasites in the red blood cells, and this is very easy. This is a falciparum malaria. The diagnosis is of course falciparum malaria. The diagnostic methods are the peripheral blood smear, the thick and the thin smear, and the rapid diagnostic kits are available where you look for HRP2 or PLDH antigen test. Of course, the severe form is the severe malaria, where there is cerebral malaria, there is severe anemia, hypoglycemia, there can be renal failure, ARDS, shock, and so on. The first line drug they have asked in India, but in the history if you see, the patient is from Assam. So of course ACT based regimens are there. In the northeast states you go for ACT-AL, that is the artemether lumefantrine combination, and for other parts of the country you go for artesunate, sulfadoxine and pyrimethamine. So as per the region involved, you have to give the treatment. In this question it is Assam, so you have to go for ACT-AL regimens since it is a part of northeast. And the complications are cerebral malaria, black water fever, ARDS and renal failure. So malaria is another important topic which you can't skip, which you should know right from A to Z about the topic. And they can ask you about the chemoprophylaxis, they can ask you about the Vivax, they can ask you about the hypnozoids, anything can be asked. This is just one scenario, and falciparum malaria is more commonly asked. This is more hot topic and favorite for the examiners. Then the next question, a 58-year-old male with a history of smoking and hypertension presents with sudden retrosternal chest pain radiating to the left arm, associated with sweating and nausea. On examination, BP is 90/60, pulse is 48 and ECG is shown. What is the most likely diagnosis? Which coronary artery is involved? Two complications, drugs which should be avoided in suspected RV infarction, definitive management. So if you see the typical history, there is a retrosternal chest pain with radiating to the left arm and associated with sweating and nausea. Also patient have a history of hypertension and smoking. And if you see the ECG, there are typical ST elevations in lead 2, lead 3 and AVF. I think you can come to the vascular territory as well. And definitely the diagnosis is inferior wall MI, because the area which is involved is the lead 2, lead 3 and AVF. And artery of course is right coronary artery. Complications are bradyarrhythmias, right ventricular infarction and hypotension. And you have to of course avoid nitrates when RV infection is suspected. Definitive management is of course primary PCI in a PCI capable center and thrombolysis in a non-PCI center, but definitely you have to refer the patient ultimately to a PCI center. So again, myocardial infarction is a so important topic which you can't skip, and any type of MI can be given, and you are expected to know everything right from the basics till the advanced treatment. And you can even be asked in the table vivas about the MI, and you can also be given ECGs in the table. So you should know about the different territories, different types of ST elevation and the localization of the artery involved. Then the next question, a 40-year-old male presents with a progressive shortness of breath, easy fatigability, swelling of legs for the last 6 months. He gives a history of alcohol consumption and a frequent respiratory infection in childhood. On examination, he has elevated JVP, pedal edema, displaced apical impulse and a S3 gallop. X-ray shows a cardiomegaly, echocardiography is shown below and a reduced ejection fraction noted. What is the most likely diagnosis? Two common causes, key echocardiography finding, two main drugs and two complications. So you can clearly see all four chambers of the heart in the echo, and all are so much dilated. So there is no other diagnosis other than dilated cardiomyopathy. And as per the history also, the alcoholic history along with kind of reduced ejection fraction and cardiomegaly and the image which is shown, there is no other diagnosis than dilated cardiomyopathy. And cardiomyopathies again are very important topic which you should not skip. So the answer here is dilated cardiomyopathy. Causes of course alcohol being one of the most common, then viral myocarditis, genetic causes are there, nutritional deficiency of which thiamine deficiency is noted, and chemotherapy. Echocardiographic finding, you can see dilated cardiac chambers with reduced ejection fraction and global hypokinesia. Drugs you can use are the ACE inhibitors, ARBs with the ARNIs, any one, beta blockers, diuretics, aldosterone antagonists and so on. Complications are of course heart failure, arrhythmias, VT, VF or AF, thromboembolism and sudden cardiac death. Then the next question, a 62-year-old male with a history of long-standing hypertension, ischemic heart disease, presenting with progressive breathlessness, NIHA class 3, orthopnea and bilateral pedal edema. On examination is elevated JVP, bilateral basal capitation, hepatomegaly and pitting bedal edema. Chest X-ray shows cardiomegaly with pulmonary venous congestion, and echo reveals an ejection fraction of 30%. Kind of a similar history to the last question, but here they have not mentioned any image of echo, but the question is kind of similar. And they have asked what is the most likely diagnosis, two common causes, two clinical signs, suggestive of right-sided failure, two drugs that improve survival, and two complications of the chronic heart failure. So diagnosis is very clear, chronic heart failure with reduced ejection fraction, that is HFrEF. Causes are the ischemic heart disease, one of the most common cause, hypertension, valvular heart disease, and dilated cardiomyopathy. Right heart failure signs are the elevated JVP, hepatomegaly, ascites, and peripheral edema. Drugs which are known to improve survivals are the ACE inhibitors, ARNIs, the beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. They are known as the Fantastic Four, the 4 important drugs which are known to improve survival. And the complications are the arrhythmias, thromboembolism, renal dysfunction, and sudden cardiac death. So this is another important topic which you should know thoroughly. You can be given a long case, you can be given a short case, you can even be asked anything about heart failure. So it's a very important topic, you can't skip. Then a 23-year-old known type 1 diabetic presents to emergency with abdominal pain, nausea, and rapid deep breathing. Family reports he had fever and missed his insulin dose. On examination, he is drowsy, dehydrated, tachycardic, hypotensive, and technique with Kussmaul's respiration, and his breath has a fruity odor. Investigations, the ABG is given along with blood glucose 420, arterial pH of 7.15, bicarbonate of 10, serum ketones are positive, and potassium is 5.6. I think this is a very clear-cut history which we all have encountered day in and day out in emergencies, and is the most common emergency question which can be given in OSCEs or can be asked in the table vivas. I think you have already figured out the diagnosis. So the questions are: what is the most likely diagnosis, biochemical triad, the initial fluid of choice, how is potassium managed in this condition, and 2 common precipitating factors. Of course, the diagnosis is the famous diabetic ketoacidosis. Triad is the hyperglycemia, metabolic acidosis, and ketonemia or ketonuria. Isotonic saline is the first initial fluid of choice. Potassium management: if the potassium is more than 5.5, no supplementation initially. If it is around 3.5 to 5.5, that is normal. You have to start replacement along with insulin. And if it is less than 3.5, you have to correct the potassium first and then you have to start insulin. And precipitating factors are infection, missed insulin as in this case, MI, stroke, pancreatitis, trauma. So diabetic ketoacidosis you can't skip. This is the most common question asked in the emergency table and you should know it thoroughly. Then the next question: a 30-year-old woman presents with perioral tingling, muscle cramps, carpopedal spasm. She had undergone thyroid surgery 2 weeks ago. On examination, she has a positive Vostek and Trocheus sign. ECG shows QT prolongation. What is the most likely diagnosis? 2 common causes, 2 classical clinical signs, ECG finding, and emergency management. I think a very clear-cut history is given: perioral tingling, muscle cramps, carpopedal spasm. Also 2 most famous signs are given already, is the Vostek's and the Trocheus sign, and the ECG is showing QT prolongation. So I think you have guessed the diagnosis. It is hypocalcemia, likely post-surgical in this case. Causes are hypoparathyroidism, vitamin D deficiency, chronic kidney disease, acute pancreatitis, and hypomagnesemia. The clinical signs, of course, is the Vostek sign and the Trocheus sign, carpopedal spasm, laryngospasm, seizures, etc. ECG, the typical is a prolonged QT interval, and emergency management, definitely you have to correct it by giving calcium gluconate IV 10%, slow infusion with cardiac monitoring. Then next question: a 55-year-old male with type 2 diabetes on insulin therapy is brought to emergency with sweating, palpitation, confusion, irritability. On examination, he is diaphoretic, tachycardic, and drowsy. His capillary blood glucose is 42. So no rocket science, it's directly clear cut from the history and from the biochemical parameter given. But let us go through the questions. So what is the most likely diagnosis? Components of Whipple's triad, 2 common causes of this condition in diabetics, immediate management in this patient, and what is the long-term preventive strategy for recurrence. So very easy question: less than 45, it's hypoglycemia, and the kind of history it is given, it's hypoglycemia. Whipple's triad, symptoms of hypoglycemia should be there, blood glucose should be less than 55, and resolution of symptoms should be there after glucose correction. That is a triad. Causes in diabetics are definitely: first is the excess insulin, and then a missed or a delayed meal, alcohol intake, renal or hepatic dysfunction, and exercise without adjusting the dose. Immediate management is definitely you have to give IV dextrose, 50% dextrose, or you can also go for oral glucose depending on the patient is conscious or unconscious, and also IM glucagon can be given. Prevention, you have to educate the patient. Regular meals should be given. You have to adjust the dose of insulin accordingly. You can also go for continuous glucose monitoring. Then the next question: you are asked to examine the abdomen of a 30-year-old male with abdominal fullness and left upper quadrant pain. On examination, there is suspicion of splenomegaly. Mention the method of palpating the spleen. Mention the method of percussion for spleen. How to differentiate splenic enlargement from renal mass, and mention 2 causes of splenomegaly. So this is completely a clinical question which can also appear in OSCE. This is mainly a clinical scenario which is generally asked bedside in long cases where you are asked to palpate the spleen or percuss the spleen. You are asked about different methods of splenic palpation or percussion, but nowadays what they are doing is they are asking such clinical questions in OSCEs also, and they are testing your knowledge. So you should definitely know about it, and if you have prepared for a clinical examination methods, definitely you know this question. So of course we know there are various methods of palpating spleen. They have asked 2. One is bimanual method, one is the hooking method. The percussion is drop space percussion, Cassell's method, Nixon's method. You can read about the details from your clinical method books. In OSCEs, you don't have to write in detail if not asked. Then differentiating renal mass from spleen. So this is very important. Spleen has notch, it moves with respiration and it cannot be insinuated between the costal margin and the mass. But kidney, they have no notch, it is bimanually ballotable and it does not move with respiration as freely. So the important causes are infective causes, malaria, kala-aza, typhoid, hematological causes like lymphoma, leukemia, hemolytic anemia and portal hypertension. Remember, whenever you are asked about causes of anything in a postgraduate examination, you should always answer by a category like infectious, non-infectious, autoimmune, drugs, toxin, in that fashion, and then you can mention about different causes under that. But never keep on blabbering random causes because that doesn't set a right impression. Always in post graduation, remember, if you can answer more in a way where you are mentioning about infections, non-infections and so on, it sets a right impression to the examiner. That's why if you are being asked about the causes, you can write like that: infective, non-infective, hematological and so on. And the last question, you are examining the nervous system of a 45-year-old male who presented with the right-sided weakness. The examiner asks you to elicit Babinski sign. Describe the method of eliciting the Babinski sign. What constitutes a positive Babinski response? What does a positive Babinski sign indicate clinically? Name 2 other methods or variants to elicit the plantar reflex and mention 2 situations where Babinski sign may be normally present. This question will be a homework for you. You can type the answers in the comment section below. I will be posting the answers at max within 48 hours. I would like to see your response. This is another bedside clinical question which can be asked in this way and which have been asked previously in the DNB OSCE exams. So I will be waiting for the answers. I hope this entire OSCE sessions, both the part 1 and part 2, were helpful, and I hope you got an idea about how the OSCEs are being conducted across the various DNB exams all over the India. The OSCE questions are definitely not tough. They are meant to make you pass. 80% of the questions are easy and you can easily score around 75 to 80 in OSCEs. The key to score high marks in OSCEs is to read the question well and then attempt all the questions. And also sometimes the clue to the answer is in the question itself. So try to be smart while reading the question and extracting the answer. Besides these 2 videos which I have done, you can also read a book by Dr. Narendra Pal sir. He is our DNB academic coordinator. He has written a very good books. He has included almost all clinical scenarios, including all levels of difficulties. You can also refer to White Army YouTube channel where they have various OSCE sessions by Dr. Archibald sir. And of course, these 2 videos I hope will help you and give you a complete idea and insight about how the OSCEs are being conducted and what are the expected questions and the level of questions which you can expect in the DNB exams. Please practice these questions. Be very thorough with it. I wish you all the best for the exam. Please make sure to subscribe to my channel and keep supporting. It takes a lot of hard work to prepare these videos, to find time amidst my duties as well, and also share it with your friends who might need these. I have also made a lot of content on DNB regarding how to approach the DNB surgery exams, approach the DNB anesthesia exams and so on. You can watch the complete playlist somewhere in the I button. Also, if you have any doubt, you can put it in the comment section. I will be happy to help, or you can also DM me in my Instagram account at aspiring endocrinologist and I will definitely get back to you. So thank you for watching this till the end. If you have not watched part 1, please go back and watch part 1 as well. You can find all the important documents in the link below. You can download it and start practicing. All the best for the exam. Thanks for watching. Keep supporting. Take care. Cheers.